Very good morning to all of you. I warmly welcome everyone for today's Sunday morning for today's CPD program organized by Government Medical Officers Association and Society for Health Research and Innovation. Our webinar link will be open to you from 9 a.m. to 9:50 a.m. and no late attendees will be entertained thereafter. Each attendee should attend till the end of the webinar to obtain the e-certificate for participation, and you have to answer questions within the Google form and you will be given CPD points which are strictly adhered to NCCPD guidelines. Anyway, the e-certificate will be given to you regardless of the CPD points. The link for applying e-certificate will be closed few minutes after the end of the session, and the chat box will be open to you for your queries. All questions will be answered at the end of the webinar. Also, we kindly ask you to mute your microphone and switch off your video to avoid any interruption during the session. So, now let me introduce today's speaker, Dr. Anusha Ambanwala, Consultant Emergency Physician at Teaching Hospital Ratnapura, to do the today's session on approach to syncope in emergency department. So it's over to you, madam.
So good morning, Sachini, and good morning, all of you. So my session today is regarding approach to a patient with syncope in our emergency departments. First, to get an idea what we are dealing with and what are the cases that we usually come across, we'll go through a small clinical scenario before the start of the lecture. So just think of a 65-year-old otherwise healthy female who was found unconscious on the ground, and she has arrived to the emergency department, and we all say that she is back to her baseline mental status without no other complaints, and her vitals and physical examination unremarkable. So what do you think here? What's happening here? Is this syncope? Is this what we call syncope? Or is there any possibility of any other differential diagnosis? And is that history that we got enough for our diagnosis? Or are there any other key features in the history of physical examination that we should go through to take a medical decision? How we should work up this patient? So that's what I want you to learn today. So my aims of the presentation today is to find you all make the ability to identify syncope and the difference of syncope with pre-syncope, and to see what are the causes for syncope and what are the syncope mimics, or what are the things that can look like syncope but are not syncope, and identify or know the way how to differentiate a simple fainting attack with other serious pathologies. How should we assess syncope in emergency department, and how we should arrange the disposition plan for these patients with syncope. So what is syncope? By definition, it's a sudden brief loss of consciousness followed by a spontaneous complete recovery, which occurs as a result of global cerebral hypoperfusion with loss of postural tone. So there are a few important points in the definition. It's a sudden onset thing. It's a brief period of loss of consciousness, and it's followed by spontaneous and complete recovery. So what's the difference with pre-syncope? We all have heard there are different terms: syncope, pre-syncope, vertigo, dizziness. Pre-syncope is a bit different. Pre-syncope is a similar event, but there is no loss of consciousness. So in syncope, there is a brief period of loss of consciousness. Vertigo, I know some of you have concerns, is something completely different. It's not that feeling of imbalance or dizziness. It's a feeling of surrounding being spinning around you. Vertigo is that. So pre-syncope and syncope is different to vertigo. With that, about syncope, it's quite a common presentation to our emergency department, and we all should know syncope is not a diagnosis. it's a symptom. So we have to find out the diagnosis. We have to look for the reason behind this syncope. It can vary from a benign physiological response to a life-threatening underlying condition. And also, it's important to know that we always won't be able to find the cause for a syncope. Usually, it's been found that only 50% of cases of syncope, we can find a diagnosis in our emergency departments. So why is it important? Because it's been found with the international data, 30% of the population experience syncope at one point of their lifetime. And 2 to 5% of emergency department admissions are due to syncope. And on the other hand, 1 to 6% of all hospital admissions are due to syncope. So what should be our goal? What should we aim at? So we should differentiate syncope from other syncope mimics. We have to find out the cause for syncope, especially we have to at least make sure that this is a benign cause or whether this can be due to a serious condition. And if we detect any life-threatening serious condition, we have to initiate and do the necessary treatment. And we have to assess the risk for further cardiovascular events or sudden death in future for these patients. We are going to the pathophysiology just a little bit to understand what's going on. So as I said to you, there is a brief period of loss of consciousness in syncope, which is due to global cerebral hypoperfusion. So global cerebral hypoperfusion is due to reduced cerebral perfusion pressure. If you can remember what cerebral perfusion pressure is, it's mean arterial pressure minus intracranial pressure. Mean arterial pressure, on the other hand, is cardiac output into systemic vascular resistance. We all know by medical student days, cardiac output is stroke volume into heart rate. So with all these, we can see cerebral perfusion pressure is directly proportionate to stroke volume, heart rate, and systemic vascular resistance. So if there is any reduction of either of these parameters, either stroke volume reduction or drop in heart rate or a drop in systemic vascular resistance, there can be a reduction in cerebral perfusion pressure. Thus, this can lead to a global cerebral hypoperfusion and syncope. So we know the commonest form of syncope is the vasovagal syncope. Just to show you how a vasovagal syncope can occur. If you are, for example, if you are standing, there is venous pooling towards your lower end of the body. So there is obviously a reduced ventricular filling. This reduced ventricular filling causes increased sympathetic tone and hypercontractility of these underfilled ventricles. This hypercontractility leads to activation of some mechanoreceptors in the ventricles, which with the vagus nerve pathway goes and reduces the sympathetic output. So this reduction in sympathetic output causes overdrive of parasympathetic output, which causes bradycardia and hypotension. This causes syncope. So that's the pathophysiology of the common faint or the vasovagal syncope that we all know. So what are the causes of syncope? There is a lot of classifications for the causes of syncope. Some say there is cardiac causes for syncope and non-cardiac causes, and there are some broader classifications. I would go ahead with this. There are like mainly two types, obviously, cardiac and non-cardiac, if you go through all four types. So non-cardiacs, there can be neurally mediated causes for syncope, orthostatic hypertension. The other two are cardiac, but cardiac causes again can be divided into two. One is cardiac arrhythmias and the other one is structural cardiac problems. So neurally mediated comprises majority of the causes for syncope, which is 60%, and orthostatic hypertension 15%, and cardiac arrhythmias around 10%, and structural cardiac problems around 5%. And still there is another 10% that we can't find a cause for the syncope. So we'll go through the neurally mediated causes. Obviously the common faint, the vasovagal syncope that we all know of, it's the main portion of this type of syncope. It comprises a large percentage. And then carotid sinus syncope. There can be situational syncope we all have heard, after a cough, sneeze, sometimes after some gastrointestinal stimulation, micturition, this situational syncope can happen. And also glossopharyngeal and trigeminal neuralgia are also associated with neurally mediated syncope. So we are talking about the causes for syncope. Let's move to the other type. So this is 60%. Orthostatic hypertension, what can be the causes? Autonomic failures due to different diseases. Examples like Parkinson's disease, diabetic neuropathy. These can lead to autonomic failure and orthostatic hypertension causing syncope. And volume depletion due to various reasons like hemorrhage, maybe diarrhea, and sometimes some drug effects can also lead to orthostatic hypertension. For example, like antihypertensives. So it's important for us to know that if a patient has changed the antihypertensive dose recently or that changed the antihypertensive type recently, it can be a cause of syncope as well. So this comprises 15% of all causes of syncope. Next type is cardiac arrhythmias. So what type of cardiac arrhythmias can cause syncope? Anything is possible. So sinus node dysfunction can cause a syncope, and problems in atrioventricular conduction system, and other supraventricular tachycardias or ventricular tachycardias. And also we should know there are some inherited syndromes which we all should know to identify, especially with the ECG. These things can cause syncope as a symptom, but they are deadly. They can lead to death. So it's very important if a patient presents with these syndromes to identify them and refer them to necessary units for further management. These can be long or short QT syndromes, Brugada syndrome, WPW syndrome, and arrhythmogenic right ventricular cardiomyopathies or arrhythmogenic right ventricular dysplasia. And there can be problems with, if the patient is on a pacemaker or ICD, there can be problems with malfunction of these implanted devices can lead to syncope as well. And some drugs inducing arrhythmias can be causes. So this comprises 10%. Then the structural cardiac problems as a cause of syncope can be due to a variety of structural problems in the heart, cardiac valvular problems, myocardial infarction or ischemia, obstructive cardiomyopathy, aortic dissections, pericardial disease, and some cardiorespiratory issues like pulmonary embolism or pulmonary hypertension. All these things can be structural cardiac problems causing syncope. So we have talked now about the causes of syncope. Structural cardiac problems comprises 5% of all the causes of syncope. So what's important? The most important thing is to differentiate whether the patient with syncope is having a cardiac cause or a non-cardiac cause. That is because cardiac causes of syncope has a higher morbidity and a mortality rate, so compared to the non-cardiac causes. So if a patient presents to us with syncope, we have to identify that if there is a cardiac problem and do the necessary management, because if it's a cardiac cause, it's not good to miss it, because the next time the patient presents to you, he might present to you with a cardiac arrest. So cardiac causes should be identified and treated appropriately. So we have talked about what is syncope, the definition, and the differences with pre-syncope and vertigo. We have talked about pathophysiology. We have talked about the causes for syncope. What next? Syncope mimics. Mimics means what are the other conditions that can look like syncope but are not really syncope, because they can behave like syncope because they also have a loss of consciousness. But it's important to understand that loss of consciousness in this syncope mimics is due to some other different physiological mechanism. It's not due to the physiological mechanism that I explained to you before for syncope. So they should be identified appropriately on time and managed. And management is also completely different from usual syncope. So what are the syncope mimics that you know? When you see this picture on the screen, you might understand one is a convulsion or febrile or convulsion or a fit. Seizures, the first syncope mimic. There is a loss of consciousness with seizures as well, similar to the syncope, but it's a complete different way of loss of consciousness. The reason here for loss of consciousness is decreased or disorganized activity of reticular activating system. So how can we identify a seizure from syncope? History is extremely important, not only from the patient. If you have any witness who have seen the incident, it's extremely important to take a proper history from the witness as well. We can ask about the onset of the seizure. Whether, like usually with the seizure, the jerky movements, tonic-clonic movements starts first and then the consciousness is lost. And about the duration, we all know the duration for a syncope is very short, very brief period. But if it goes beyond like 5-6 minutes, it's very unlikely that this can be a syncope. It's likely that this episode can be a seizure. Sometimes there can be differences like or difficulties in differentiating because some seizures will not have the tonic-clonic movements, but so we can look at the other features as well. There can be some other associated features. You can look at, like you all know, there can be a fecal or urinary incontinence, eyes rolling up. Those things will be helpful as well. And then syncopal episodes may also present with shaking sometimes, but that shaking happens after loss of consciousness and it's for a very brief period of time. And other important thing in understanding the differences is usually with the definition we know, with syncope, they turn back to complete normal mental state immediately after the episode. But in a seizure, this can be a post-ictal drowsiness period. Usually they take a longer time to come back to their normal mental status. They may be drowsy, having some weaknesses in their post-ictal period. So that is also a difference of seizure and syncope, which will help to understand the difference from the history. I don't want you to go through the whole this chart, but just look at the places that I have put stars. So in a seizure, myoclonic jerks usually start before loss of consciousness. In a syncope, sometimes there can be some jerks, but they usually start after loss of consciousness. So post-ictal confusion, the next thing. In a seizure, we usually see a period of post-ictal confusion, but in syncope, there is rapid recovery without any confusion. And the next thing that I forgot to tell you, we can look for this tongue biting and all those things, which are commonly seen with seizure, but not with syncope. So we are talking about the syncope mimics. We talked about seizure. The next thing is metabolic disorders. Some metabolic disorders are there which can behave like syncope. There can be some periods of loss of consciousness and may appear like syncope, but they are different. It's important to identify those things because management would be completely different as well. So what metabolic causes can lead to syncope-like symptoms? Hypoglycemia, hypoxia, heat strokes, carbon monoxide poisoning, hyperventilation, and toxic ingestion can lead to these things. But we have to understand that loss of consciousness from all those causes, all those metabolic causes, typically remain like altered, or they typically remain symptomatic until we do the appropriate management for those metabolic disorders, unless the syncope, which the patient returns back to the normal mental status or normal conscious level without any without any specific managements. So hypoglycemia, usually we can identify patient might be having some autonomic symptoms. It's not very common just to cause a brief period of syncope with hypoglycemia, but patient may have symptoms until we detect it and treat it. But we always have to suspect it, especially in a patient with diabetes mellitus who are on hypoglycemics. Next thing, exertional heat strokes. It can happen with strenuous exercise in hot environments for a long time, especially these vulnerable patients are disabled patients or elderly patients. Carbon monoxide poisoning. If there's a history of exposure to a structural fire or vehicle exhaust or space heaters on an enclosed environment, we have to suspect this. Symptoms can vary. Syncope can be one symptom, but it can vary from headache, nausea, even to loss of consciousness and death. It's especially suspicious if you find multiple patients presenting with same symptoms from a same area. So we have to suspect carbon monoxide treatment and do the necessary management. So it's completely different from syncope. We have to manage carbon monoxide poisoning there. So still I'm going through these metabolic causes as mimics for syncope. Hyperventilation is another thing. Hyperventilation may cause a transient loss of consciousness secondary to hypocapnia, causing cerebral vasoconstriction. Toxic ingestion, salicylates, narcotics, antihypertensives, those things can cause symptoms like syncope as well. So we have to detect in history if there is any possibility of ingestion of these these agents or overdose of any of these things cause this, which can be the cause for syncope. Stroke or TIA, another syncope mimic. Especially acute ischemia of the vertebrobacillus system can cause syncope-like symptoms. If it's a TIA, it's very likely that the loss of consciousness can be a brief period, can be a transient one. So we can misdiagnose this as a syncope. I'll give you some study data to see how important this point is. There has been studies that a study with 483 patients presenting to emergency department with syncope, they have found 7.7% having TIA-related syncope. And another different study of the patients, like 772 patients who have a stroke or TIA, they has had their initial symptoms. 4.9% of them has had their initial presentation or initial symptoms, either syncope or pre-syncope. So it's a significant number. These patients can have syncope as a symptom. So in all patients, especially those who have risk factors for strokes, if they present with multiple unexplained periods of loss of consciousness, we always have to think of possibility of ischemia or stroke. So I'm talking on stroke mimics. We have talked about seizures, we have talked about metabolic disorders and stroke. But others, intracranial hypertension, psychogenic pseudosyncope. Let's go to intracranial hypertension. Loss of consciousness can happen due to increased intracranial pressure, which can be secondary to many things, maybe secondary to mass lesion, maybe secondary to a SDH or cerebral venous sinus thrombosis. So consider raised intracranial pressure if it's happening secondary to a head trauma, if there is recurrent unexplained headaches, focal neurological symptoms. So that's in these instances, if the patient presents with symptoms like syncope, we have to think of possibility of intracranial hypertension. What is this psychogenic pseudosyncope? There's an appearance of loss of consciousness, but there is no true loss of consciousness. I think you have heard of psychogenic non-epileptic seizure. This is something similar to that, but there is no jerky movements. It's a form of a conversion disorder, mental problem, psychiatric problem. So it's just the appearance of loss of consciousness. There is no true loss of consciousness. So usually the patients can be young females with other psychiatric comorbidities. So we can suspect these episodes if the patient having these symptoms prolonged duration, high frequency of episodes, little or no post-ictal state, no injuries sustained from the episode, and unusual triggers. So if it's a vasovagal syncope, we all know usually patients are in one posture, standing for a long time or sitting for a long time, but sometimes these patients might tell they started the symptoms when they're lying down. So it's unusual triggers. So we have to think of these things as well. So I think I have talked to you about syncope mimics. How can we clinically evaluate a patient like this? Yes, we all know, as similar to any other condition, we have to take a thorough history, physical examination. History and physical examination is the most important thing in assessing a patient with syncope as well. So most of the times with history and physical examination, we can come into a conclusion of the reason of the syncope. But if not possible, ECG is the next essential investigation that we should be doing. ECG helps us a lot, especially to identify those cardiac causes of syncope. As I said to you before, cardiac causes are associated with higher morbidity and mortality. So if we don't have a clue from history and physical examination, we should go for an ECG to see whether there's anything significant. Other investigations, anything is not essential. Like we can't tell you have to do this to all patients with syncope, other than this first three, history, physical examination, and ECG. Other things, depending on the scenario, you can think of the scenario, you can clinically decide what sort of investigations that you should be doing. For example, if it's a patient with diabetics or oral hypoglycemics coming with a syncope, you obviously do a sugar level to find whether there's a hypoglycemia. On the other hand, if it's a young lady coming with abdominal pain and some vaginal bleeding and a syncopal episode, you would definitely do a pregnancy test to see whether she's pregnant, whether there's a possibility of ectopic pregnancy. Likewise, you can clinically decide what other investigations should be done depending on the clinical scenario. So history, what should we gather from history? About the event, we have to take a detailed history, detailed account about the event, because we haven't seen the account. It's either the patient who knows what happened around the event, or if there's any witness, the witness knows what happened during the event. So we have to take a good history about the event from the patient, and if a witness is available, from the witness as well. So what were the triggers, and was there any prodromal symptoms? Prodromal symptoms means, was there any, like before the event, was there any sweating, feeling of warm feeling, nausea feeling? Were there any prodromal symptoms? So what was the triggering event? Sometimes, vasovagal syncope can occur with like severe pain, sometimes fear, sometimes with some medical, like fear of medical procedures and all those things. So what were the triggering event? Were there any prodromal symptoms? What was the patient doing right before the event? What was the posture? Was he or she standing for a long time? Was there any movements noted, which can be due to a seizure? So likewise, we had to take a detailed history of what happened immediately before and during this event. Were there any injuries like tongue bite during the event? So which is a possible reason, a possible differential diagnosis of syncope. There is a seizure possibility. And how was the duration? Usually if it's just a simple faint or a common syncope, it's usually a short duration, but if the duration is prolonged, it can be a seizure or some other differential diagnosis. So we have to look for the duration of the event. And how was the recovery period? Was there a complete recovery rapidly after the event? Or was there a period of confusion or some weakness, which is possible with some seizure disorders? So we have to take a detailed history of the event in these scenarios. Just to tell you about vasovagal syncope, which is the commonest form, how to identify vasovagal syncope from the history. We all know there are these three P's: prodrome, provoking factors, and posture. So what is prodrome? Prodrome is before the event. If usually patients, they experience some difference to their body, like feeling of coldness or warmth to the body, some sweating. And we can ask the patient whether he or she has experienced those things before the syncope. And usually they have a provoking factor, some sort of a pain or experience to a medical procedure or something like that. So was there a provoking factor? And the posture, usually they may be standing, or usually they may be like sitting for a long time or standing for a long time. So those things, prodrome, provoking factors, and postures. So those things can help us to identify vasovagal syncope from the history. Just a little bit more details to differentiate neurally mediated syncope with orthostatic hypertension and cardiogenic syncope. just a few more things to add up. So if it's a neurally mediated syncope, we know that it can be due to these posture changes, as I said to you before, prolonged standing, and this prodrome of nausea and feeling of hot coldness to the body, and even can be after a meal or a situational syncope, like after a cough or sneeze, and sometimes carotid sinus stimulation due to turns of head, shaving and tight collars. These things can be causes of neurally mediated syncope. And also sometimes syncope can occur, neurally mediated syncope can occur after exertion, but it's not during exertion. If it's neurally mediated, usually it's after the exertion period. And on the other hand, orthostatic hypertension, it usually happens after changes of posture. We can ask from the history about any changes of antihypertensives or any change of antihypertensive doses, presence of other autonomic problems like Parkinson's or other autonomic neuropathies, usually occur when they're standing and when they're sitting for a long time. To differentiate cardiogenic syncope, it's important for us to take a lot of details from the history. We can ask them whether they had a previously diagnosed cardiac problem, or whether they have a family history of like cardiac problems which comes in family, or family history of sudden cardiac deaths, and whether this happened during exertion, which is an important feature in identifying the cardiac syncope in the history, and also whether they experienced any palpitations, chest pains, difficulty in breathing with this syncopal episode, or even just before or immediately after the syncopal episode. These things in the history will help us to identify cardiogenic syncope. So exertional syncope. Syncope happening while the patient is exerting in absence of a prodrome or a trigger. What do you think it can be? So patient is doing exercises, physical exercises, and there's a syncopal episode, and there are no prodromes, there are no triggering events. What do you think? There's high chance that this can be a cardiac etiology. So it's not a simple neurally mediated syncope. So there is high chance this can be a cardiac origin of syncope. So this, I think I have already mentioned, we have to take a proper past medical history of the cardiac history and venous thromboembolism risk factors, family history of cardiac illnesses or sudden unexplained cardiac deaths, and similar previous episodes, whether the patient has had experienced similar previous episodes of syncope. Syncope plus, I'm just going to discuss few things, few important clues that we can take from the history that can lead our mind into some differential diagnosis for this syncope, but they're just possibilities, but not absolutes, but just see about these things. If a patient comes with syncope, complained of a headache around the event as well, so syncope with headache, we can think of some other differentials, whether this can be SH, whether this can be due to increased intracranial pressure, and reversible cerebral vasoconstriction syndromes or cervical vessel dissections. These things can be possibilities if a patient presents with syncope and headache. And then if it's syncope with chest pain, think of myocardial infarctions, pulmonary embolisms, aortic dissections, tamponade, or other cardiac related problems. Syncope associated with shortness of breath. What can be the possibilities? Pulmonary embolism, dysrhythmias, maybe MI, aortic stenosis, those things are possibilities. Furthermore, some more syncope plus things. If patient has experienced palpitations before or immediately after the event, so think of dysrhythmia, possibility of cardiac arrhythmias. Syncope in a young lady with some abdominal pain and vaginal bleeding, whether this can be an ectopic pregnancy. Syncope with some abdominal pain or back pain, possibly if it's an old patient, possibility of an abdominal aortic aneurysm, dissection, sometimes maybe GI bleed. If it's a young female of fertile age, maybe a ectopic pregnancy as well. So we have to think of all these associated symptoms to come into a conclusion or come into a diagnosis of possibilities or the proper cause of the syncope. Syncope with vomiting possibility, MI is there, and GI bleed is another possibility. So what should we be looking at our physical examination, which can help us to come into a diagnosis or a conclusion? We have to do a targeted, good examination of the cardiovascular system and nervous system. So I'm not going to tell you each and every point what we should be examining in cardiovascular system. We all know that. But specifically, you look for bilateral upper extremity blood pressures, whether there's a significant difference. And listen to the heart, whether there are any murmurs suggestive of cardiac valvular issues. And you have to do a complete neurological examination to see whether there are any focal deficits, and a mental state examination as well, obviously. And with that, also we have to look whether there are any injuries sustained during the period of syncope. Due to the trauma, whether there are any possible injuries that have sustained. So we have to target all those things during our physical examination. I'm going through another small case scenario before going into ECG evaluation of syncope. We have talked about the history, we have talked about physical examination. So we'll see a small case scenario whether we can come to a conclusion. So it's a 73-year-old gentleman who has past history of congestive heart failure and hypertension. He presents to you with an episode of loss of consciousness while he was walking, and he denies prodromes, denies head trauma or traumatic injuries. He says no to chest pains, no shortness of breath or abdominal pains. He says the loss of consciousness only lasted for about 10 seconds, and he quickly returned to his normal baseline. What do you think? He says he's currently asymptomatic, and he asks you whether he can go home. So his vitals looks like this: heart rate around 83, with a blood pressure of 145 by 93, saturation around 94% on air, respiratory rate 18, and temperature all right. So with this history, what do you think? What's your conclusion? Do you think of some cause of syncope, or on the other hand, can you risk stratify this patient? Can you safely send this patient home, or do we need to do something else, some other investigations to see whether there is another dangerous cause for this syncope? Another case. Look at this one. So it's just a 20-year-old young female. She's 33 weeks pregnant in her first pregnancy. She said no past medical history. And she has come to us with a loss of consciousness for a period of 2 minutes. She denies prodromal symptoms. She says she didn't have any fevers, chills, nausea, or vomiting, no history of shortness of breath or chest pain, or she says no to abdominal pain as well. So she's just 20 years, 33 weeks pregnant in her first pregnancy, loss of consciousness for 2 minutes. During her loss of consciousness, it's been reported that her eyes reportedly deviated to left side, and she had a urinary incontinence. And it took about 15 minutes to return to baseline. Currently, she said she is fatigued and there's a blurring vision bilaterally, otherwise no symptoms. So you may be having some differentials in back of your mind. With that, her examination revealed heart rate 91, respiratory rate 18, and her blood pressure is 173 over 111. Okay, so what do you think this can be? Is it just syncope, or is there something else going on? So we'll go to these two cases at the end of the evaluation. So still we are on evaluation. We have done the history part, we have done the physical examination part, and then the next important thing is ECG. So what should we be looking at a ECG in a patient with syncope? We obviously look at ischemia. We all know how to look at ischemic changes in a ECG, conduction abnormalities. And there are, as I said, there are these other syndromes and things which can cause symptom of syncope, but they are very deadly syndromes. They can even lead to cardiac arrest. These things include prolonged QT syndromes, short QT syndromes, and WPW syndrome, Brugada, hypertrophic cardiomyopathy, and even arrhythmogenic right ventricular dysplasia. And we also have to look at other dysrhythmias or other cardiac arrhythmias as well. So if it's clinically indicated, we can do a blood sugar and other routine blood test as needed. As I said, we don't have to do everything in every patient, but if it's indicated, as I said to you before, we can do a pregnancy test, we can do sometimes full blood count or electrolyte levels, or sometimes if it's MI is suspected, we can send troponin levels. So that depends on the case scenario. Just a bit about cardiac syncope. I'm not going to talk everything about cardiac syncope, but I'm going to show you some deadly diagnosis that we can reveal with the ECG in a patient who presents to us with syncope. So when they present to us with syncope, if we detect these things, we are like saving their life. In the next time, if we miss this diagnosis and we send those patients home, the next time they present to us, that may be then, that may be that we can see the patient in a cardiac arrest maybe. So it's very important to detect this patient with the ECG to find whether these deadly diagnoses are there. These things are just reminding you, you can have different methods of ECG interpretation. I'm not going to teach you ECG interpretation right now. So this is one way that I assess a ECG. The initial letters hearts. Initially look for a heart rate and rhythm, then look at the electrical conduction. That means the PR interval, QRS, and the T wave, and then look at the axis, then R wave progression, then whether there's a tension or whether there's a hypertrophy of a ventricle, and then ST wave changes. So this is my way of assessing, but you can have different other interpreting techniques, which is completely all right. So we'll move. What do you have to look for in an ECG in a patient with syncope? Anyone will look for ischemia or infarction, and anyone knows how to identify ischemia and infarction. I don't think I have to tell you it. And then dysrhythmia, we all know we should look for dysrhythmias. And there are some other things that I'm happy to teach you at this moment. So we'll look at this ECG. Do you see anything significant in this ECG? So that's a young 25-year-old gentleman who had a syncopal episode while he was running to the bus, while he was exerting. And it's a brief period of syncope, and he presents to you. So with this evaluation to you, what do you think? What changes are there, do you think? So heart rate wise, there's a marginal tachycardia. Electrical conduction, how is the electrical conduction? Looks all right. And then cardiac axis. What about the R wave, QRS complexes? If you look at the QRS complexes, they are large voltage QRS complexes, significantly large voltage QRS complexes in a young patient. So what are the possibilities? This is a hypertrophic cardiomyopathy. We have to detect these things with ECGs. We have to suspect these things with ECG. So when you see this, we can send this patient to echo, preferably a Doppler echocardiogram, to diagnose it correctly, and then we can do the necessary management further on. So it's very important to detect these patients when they present to you with the first time with a syncope. If not, if you send these patients home, the next time you see the patient, he may be in a cardiac arrest. Second one, so look at this one. So who's this patient? This one is a 55-year-old male. 2 minutes of syncope while he was walking. Yes, while he was walking. So what are the changes here? With your interpretation techniques, you can think of the abnormalities. Heart rate seems to be all right. Electrical conduction, how is the electrical conduction? Looks all right. But there is some appearance of a right bundle branch block. If you look at the V1 and V1 and V2, it looks like there's a right bundle branch block, and axis looks fine. R wave progression, okay. Tension, there is no. ST wave changes. There is some with this right bundle branch appearance, there is a curved ST segment elevation in V1 and V2 leads. So what is this? I think you have heard of this, Brugada syndrome. It's a cardiac arrhythmia which was like found in 1980s, I think. It's thought to be a sodium channelopathy. These patients are at high risk. They can go into VF and VT cardiac arrest if it's not been detected before. They can initially present with syncopal symptoms, but at any point they can present with cardiac arrest with VF or VT. And also the age, they can like present with a small younger age up to about 70, 80 years. So there is no age limit. They can present at any age. So this changes are specifically seen in V1 and V2 leads. There are a few different types, but it's not important at this level. But see, look at the V1 and V2 in the first picture that shows that curved ST elevations that I talked to you before, which is more significant for this Brugada syndrome. And the second picture, there's this saddleback appearance, which is also sometimes seen in the Brugada syndrome, but it's less specific than the first type. So if you see any of these with your suspicion whether this can be a Brugada syndrome, you can refer him to a cardio-electrophysician, preferably for further evaluation. They might need ICD further for their further management. ECG number 3. Look at this one. Can you see anything significant? So it was a 20-year-old, previously well, with a period of half an hour of palpitations coming with some pre-syncopal symptoms. At the time of presentation to you, he looks perfectly all right. So he has had a period of palpitations, and this is the ECG. Do you see anything significant? Go ahead with your interpretation techniques. Heart rate looks all right for me. And there is, how about the conduction? If you look at the PR interval, it looks a bit short. When you see an ECG with a short PR interval, navigate through the ECG to see whether you see a delta wave. If you have heard of a delta wave is a slurred upstroke of the QRS complex. I think I see that in this ECG. I will show you. So this is WPW, where we find a short PR interval with a delta wave, which is a slurred upstroke of QRS complex. So this is the delta wave and the short PR interval that we see in WPW syndrome. So if you see this, so you have diagnosed a WPW syndrome, and you can refer these patients to a cardiologist for further management, which is also an important diagnosis if we can make it, and that will help to save a patient's life. We'll next move to the next ECG. So that's a 38-year-old lady presenting with query. They're not sure whether this is a syncopal episode or a seizure episode. Possible history of a medication overdose as well. So this is the ECG. What do you think? Sometimes when we look at the ECG, we can obviously see there is some abnormality. If you think about the electrical conduction, look at the QT interval here. You can calculate it as well with the formulas, or sometimes some ECGs, they give the correct, like calculated QT interval. So it looks that the QT interval is prolonged here. So it's a prolonged QT interval here. So there's a possibility of a medication overdose as well. So it's important to diagnose this and do the initial management. If not, patient can go into this. So what is this? That's a polymorphic ventricular tachycardia, which we call Torsade points. So before this, it's better if we can diagnose the patient at this stage and treat or do the appropriate management. ECG number 5. Just to show you this, if you have seen this change, this is another arrhythmogenic situation which the patients can come with syncope. If you have heard of Epsilon Wave in ECG, if you really look at the ECG, just after the QRS complex, there's this wavy appearance. It's clear in this picture. So this is called the Epsilon Wave. So if you in a ECG, in a patient with either syncope or palpitations, or sometimes even they can present in cardiac arrest as well. So there's these changes, T wave inversions in V1 to V3 in absence of a right bundle branch block, and the epsilon wave, that's the one with this arrow, and localized QRS widening in V1 to V3. So this is the possibility, arrhythmogenic right ventricular dysplasia. If you diagnose them, they will save their lives. If not, they may present with a cardiac arrest the next time. Okay, I think I have talked to you few important ECGs of the patients who presents with syncope. So we can, in cardiac syncope, we can detect these high risk features in the history, as I said to you before. Palpitations, having no prodromal symptoms, occurrence during exertion, and presence of chest pain. Don't forget your ECG and then interpret it properly and try to find possible abnormalities in the ECG. Sometimes point of care ultrasound may help you to look into some things, like if the patient is having obvious hypertrophy of hypertrophic cardiomyopathy, you might see with your echo probe, you might see the hypertrophied cardiac valves as well. Decision rules. We all know for some, like for clinical conditions, there are some clinical decision rules. For example, we have Gray's decision-making rules, or like risk stratification rules, Gray's for acute myocardial infarction, Wells for pulmonary embolism, Wells for DVT. So syncope also have some decision rules, if you have heard of them. There are few. San Francisco syncope rule is one of them. There are like advantages and disadvantages of all these, just for you to make aware of. So San Francisco rule is from all these criteria: presence of a heart failure, patient's hematocrit, ECG abnormalities, shortness of breath, systolic blood pressure. With this is the mnemonic to remember these five criteria. This San Francisco syncope rule has a high sensitivity, so but the specificity is low, or the ability to rule out a significant pathology is low. And they have found with this rule, it just increases the admission rate, but on the other hand, it also does not correctly risk stratify elderly patients with syncope as well. So there's another one which we call Canadian syncope rule. So this one also has a lot of criteria. If you just go through these points, you can see it has elevated troponin levels as well, which is a drawback to these risk stratification rules, because we can't be doing troponins to everyone who are presenting to us with syncope. So this one also has been validated in Canada in major Canadian emergency medicine departments, yet to be done external validation in other countries, but it has a high sensitivity as well, similar to the previous one. But again, specificity here is lost. But compared to the previous San Francisco rule, they said this is far more better for elderly population. But the drawback is it needs a troponin, which goes beyond our initial lab workup. We all know it's not possible to do a troponin for each and every patient who presents to us with this syncope. So that's the drawback of that. There's faint score, which is specifically made for more than 60 years old patients. The problem here as well, the criteria includes troponin as well as BNP. So there's a problem that it needs both BNP and troponin. With these multiple things, they have finally come into a say that clinical judgment is still far more important. No clinical prediction rules are sufficient enough to accurately replace the clinical judgment. So your clinical judgment is the most important thing. And the problems with the risk stratification rules, most of those rules underestimate the elderly population. So the clinical judgment, if you can do it correctly, is the best strategy for management. Syncope prediction rules, you can take them as helps to do that, but your clinical judgment plays the major role. Okay, so how should we manage these patients? if you find any obvious cause, we have to treat the cause first. If there is no obvious cause found, you have to think of a plan of disposition for this patient. First, risk stratify and see what we can do for this patient. If you have these features, you have a lower threshold for admission. If the syncope is unwitnessed, no one has seen this syncope, there's a lower threshold for admission. Or if there are significant risk factors like cardiovascular disease, suspected arrhythmias, patients on cardiac pacemakers or ICDs, these patients coming with syncope, they have a lower threshold for admission, especially elderly patients and other suspected cardiac causes as well. So these patients, we usually don't think of directly sending back home. We think of admission, at least for a period of observation or further investigations. So if the patients are having high risks, if you find any obvious cause which has to be managed on time at that moment, we have to start the management for the underlying etiology. We have to do the specific thing that we should be doing. And for patients who have high risk for arrhythmias, we have to admit those patients. So what can we do for the low risk group? If it's low risk, there are no cardiovascular risk factors and a normal ECG, normal vitals. And if the patients, that's the commonest presentation that we get. If the patient's history reveals that this is possibly a clear vasovagal mechanism, these patients can be discharged home. So no cardiovascular risk factors, normal ECG, normal vitals on examination, and history says that this is possibly a very likely to be a vasovagal mechanism for the syncope, we can send those patients home. But even with low risk, without a clear cause, maybe we can keep this patient, like there is no obvious cause for the syncope. We can't tell with this whether this is clearly a vasovagal one, but patient is not having significant risk factors. So what can we do to that group of patients? We can either keep them for a period of observation. Depending on the scenario, we can think of doing further investigations, blood investigations. Sometimes with that, we might need to admit patient for a longer duration for further investigations. Who are these intermediate risk patients? So think of, for example, think of an elderly patient with a likely mechanism of vasovagal syncope, or a younger patient with some cardiac risk factors, but no obvious cause that needs direct management or life-threatening condition at that moment, and a normal ECG. So those patients can be taken into intermediate risk group. They may need further observation with, depending on the clinical scenario, with further investigations. So we can consider them for hospital admission for a short duration. They might sometimes need outpatient follow-up as well. So can you remember our case one? This patient, can you remember this one? 73-year-old male patient with history of this congestive heart failure and hypertension, and this short period of loss of consciousness. So at the moment when he presents to us, he looks perfectly normal with these vitals. So how do you risk stratify this patient? Are you happy to send this patient directly home, or do you want anything else to be done? Concerns are, there are possibility of a cardiogenic syncope because there's a history of hypertension and heart failure. And if you think of the history again, the syncope has happened during a period of exertion. And reportedly that person has told that he didn't have a prodrome. And when they have done an ECG, it has shown LVH, voltage criteria meeting LVH, and some non-specific repolarization abnormalities. And chest X-ray has showed a cardiomegaly. So they have done a chest X-ray depending on his clinical presentation with heart failure and all. So now with this, you know, this patient is not a candidate just to send home. He needs admission for further evaluation. Let's look at our case number 2. If you can remember, this 20-year-old young lady in her first pregnancy, 33 weeks pregnant, a period of loss of consciousness for 2 minutes. And during this period of loss of consciousness, she has reported deviation of eyes to left with urinary incontinence, which looks like a convulsion episode, right? And on examination, she has had a blood pressure, high blood pressure, pregnancy, 33 weeks pregnant with a high blood pressure as well. So what's the possibility? Pregnancy, the story concerns a seizure with these features: eye deviation, urinary incontinence, and prolonged period to come back to baseline, and hypertension on arrival. So what's the possibility? This history consists with eclampsia. She needs immediate management, IV magnesium and immediate management for eclampsia. Then she needs admission to obstetric ward. So that's the difference. So this can be just a syncopal episode. This can be some other cardiac causes, or this can be some mimics of syncope presenting to us in a similar manner to a syncope. So we need to identify those things and do the appropriate management. So to wind up, I'll tell you the take-home messages. We have to identify true syncope. Identify syncope from its mimics. It's very important to do a proper clinical judgment. We can use the risk stratification tools as aids for our clinical judgment. ECG is extremely important tool in assessing a patient with syncope. So diagnosis of exact cause of syncope is not always possible, but try to make sure whether this is a cardiac cause or try to see whether this is a cardiac cause or a non-cardiac cause. We have to risk stratify these patients, rule out critical diagnosis, and treat as needed. And also, not to forget, just look whether there are traumatic injuries due to the syncopal episode which need further management. So those are the take-home messages of my presentation. I think you have learned something about syncope and its management and syncope mimics as well. Thank you so much for listening. These are few of my references.
Madam, for your excellent and very informative lecture on syncope. This is a condition which everyone should not consider the life. So, there are no questions in this chapter.
I think I have answered this question.
All participants can find this lecture on 3 YouTube channel in 2 days. You can go through it again to cover up your gaps in knowledge. And the info certificate will be sent to the chat box, and you can apply. For the certificate via that. Also, we appreciate your comments on behalf of future lectures. So I thank again Dr. Anusha Ambangala, a consultant in emergency physician from Teaching Hospital Ratnagiri, for allocating our precious time with us today. Finally, I thank all the participants for joining with us.